Hello everyone. So in the last part of lecture, we discussed what is PROM and how to examine a patient with PROM. Now we are going to discuss the management of a patient with PROM. So initially, all patients in which we have confirmed that there is PROM, we have to admit them. And as I said, there are two main risks for this patient. First, she can go into preterm delivery, and then, of course, the baby can have all the complications, possible complications of having a preterm delivery. And second is having infection. Infection can be for both the mother and the baby. Okay, so it also depends how early has this event happened. Now, of course, we will start with vital signs. We will do a general physical examination and abdominal examination, specifically looking for any suprapubic tenderness. Then on speculum examination, we would have seen, of course, confirmed if there is leaking of fluid. Then we have to see what is the smell, if there is any foul smell, if there are any signs of placental abruption like vaginal bleeding. Now, at the same time, we have to take a high vaginal swab. Okay, the report usually takes a few days, so just take it and send it. Okay, and then for the patient, depending on how what is the situation, say we have to perform, at least for everyone, a complete blood count. What are we mainly interested in? Doing a white cell count basically, and neutrophils. Of course we will look at hemoglobin and platelets and rest of the things, but here we are mainly interested to see if the patient has any signs of infection. Then C-reactive protein, which is a non-specific indicator of infection, right? So if high CRP, that means there is some infection, but it won't specify whether it is chorioamnionitis or not. Then if she is afebrile, if there is no fever, then at least temperature monitoring of 4 hourly. Okay, and remember we are admitting her. Okay, so this should be part of our plan when we are telling the nurse. Okay, CTG, if she's more than 28 weeks, then it should be at least twice a day. Okay, and then if she is less than 28 weeks, or at some hospitals they start at 26 weeks, so whatever is the protocol. If it is too early, say for example 24 weeks, then just we write in the notes for the nurse to listen to baby's heartbeat every at least twice daily with a sonic handheld device. Then, if it has not been done earlier, then ultrasound for fetal presentation, especially because earlier preterm babies, they are more likely to have a male presentation. Okay, and then like a volume, what is the situation? Okay, then we have to, if there are no allergies, we have to start oral antibiotics. Okay, if she's not in full-fledged chorioamnionitis or full-fledged sepsis. Okay, so even routinely we have to start oral antibiotics. So usually, according to the guidelines, it's erythromycin, but we can even give in some other antibiotics, because usually in the UAE erythromycin is usually short, so we can give even cephalosporins. Okay. And for how long should we give? If the patient does not develop fever and if she does not go into labor, then we have to give her for 10 days. Okay, so but if there are any signs suggestive of chorioamnionitis, then we have to deliver the baby. Okay, and how to deliver the baby, that depends what is the gestational age, what is the presentation of the baby, and is the baby distressed or not. Okay, so usually augmentin, it's contraindicated in PPROM. The reason is it has been shown by research that babies who are born after taking comoxiclave and after PPROM, they are more at increased risk of having necrotizing enterocolitis. Okay, if the patient is between 24 to 35 weeks of gestation, remember we have to give them corticosteroids. But should we tocolize? Remember in tocolysis, it's contraindicated in PPROM. Okay. Also magnesium sulfate. So depending on what is the gestational age, magnesium sulfate is best beneficial before 30 weeks. Okay, of course we will start after 24 weeks. Why 24 weeks? Because 24 weeks is the threshold of viability, fetal viability. Some hospitals, they can even give till 32 or even 33 weeks. I have seen some hospitals which you also give till 33 weeks, but it depends. Like its best works when the baby is less than 30 weeks. And why are we giving it? To improve neurodevelopmental outcome. So if at any stage, so strict monitoring of vital signs, it's very important. It does not mean continuous monitoring, but at every ward round, we have to review her vital signs chart, which is the Muse chart, remember? Okay. We have to examine her. We have to ask her, does she feel unwell? We have to make sure that she does not develop fever. We have to make sure that there is no suprapubic tenderness. We check foul smelling discharge, okay? And then if her these complete blood count or CRP, usually they are performed on alternate days, but again it varies from hospital to hospital. So if there is an increase in CRP or white cell count or neutrophils, and if clinically we think that she's going into chorioamnionitis, then we have to deliver the baby, no matter what is the gestational age. Okay. Sometimes it happens that women stay stable, even like so they continue to take oral antibiotics. Their vital signs remain stable. They do not develop fever. Their baby remains stable despite having PPROM. In those cases, if it's too prolonged, right? Because if a patient has PPROM at 26 weeks, for example, and we know that it's too early to deliver, she is stable, there is no indication to deliver. So in those cases, after careful discussion and selection, we can send them home, but strictly telling them that they need to monitor vital signs. Again, in UAE, we are a bit more careful. So usually it more it applies more to countries where there is more shortage of beds and which are public hospitals. Okay. Now, don't feel overwhelmed by this slide. It's from the American College of Obstetricians and Gynecologists, because sometimes there are differences between the American and the UK guidelines, right? So do not worry about all of this. What I want to tell you is sometimes, like this part, sometimes the PPROM can happen very early, right? In that case, we do not give corticosteroids, okay, because it's no use, right? There is no need for tocolysis anyways, and then of course no need for magnesium sulfate, okay, nor recommended before viability, okay. So that's it, otherwise you don't need to memorize the slide. Now we will discuss about PROM. So what is the main difference between PROM and PROM is just the gestational age. So sometimes it happens that women have their rupture of membranes, but they are not going into labor, say at 38 weeks, 39 weeks, 40 weeks, even 41 weeks, okay. So what can be the situation? A 29-year-old woman presents to the obstetric unit at 38 weeks of gestation complaining of vaginal leaking of fluid. She noted a gush of fluid while asleep. How will you assess and manage this patient? So now what is the main difference? The main problem here is again the same. See, in PPROM, what were the two main complications? Going into preterm labor, and second was infection. Here, luckily, because she's at 38 weeks, she's already term, so there is no risk of preterm delivery, right? But yes, the one of the things is she can go into labor, and here we want her to go into labor, right? Because it's already a term baby. Secondly, is which we do not want is risk of having infection. Okay, so yes, she can develop chorioamnionitis. Okay, so but the good thing is here we do not have the risk of having all the complications of preterm delivery. But please remember that respiratory distress syndrome can happen even after 37 weeks. Okay, so 37 8 babies who are delivered at 37 weeks, I do not remember exactly, but I think still there is a risk of respiratory distress syndrome of I think 11.4%. Babies who are born at 38 weeks, still they have a risk of I think 6%. It's written somewhere in the guidelines, but they are still at risk. Okay, so a baby born at 37 weeks, it does not mean that there is 0% possibility of having a respiratory distress syndrome. It can even happen, although much uh, lower risk at even at 38 weeks compared to a preterm baby. Now, see if there is what is the management of PROM, right? Of course, it happens after 37 weeks. So first, we have to take a detailed history, like in PROM, we say, okay, how many hours since leaking? What was the amount of leaking? What was the color? Did you notice any meconium staining or greenish color? Because patients won't understand meconium. So just say, what was the color? Was it clear or green? What do you have? Did you have any fever? Do you feel unwell? Do you have pain in tummy? Did you notice any foul smelling discharge or fluid? And is the baby movement okay? Or did you have any bleeding? Is the pain continuous or is it coming and going? Right? Because continuous pain, it may be placental abruption. Okay, and pain, labor pain, we know that it is like it comes and goes. And then if she is a booked patient, review pregnancy notes to know like when was her last scan, was the baby cephalic or not, is it's a placenta low lying, what was the situation, right? Are there any other risk factors? She can be diabetic, she can be hypertensive, there can be a lot of things. Then vital signs, so signs of chorioamnionitis beginning from like is there any tachypnea, tachycardia, hyperthermia, even hypothermia can be a sign of sepsis, and suprapubic tenderness, and which indicates chorioamnionitis. If it is tense and tender, it can be placental abruption, or are there any uterine contractions. Then we check fetal lie, engagement presentation. On speculum examination, see the color of the lica, what is the amount, is it meconium stained, is there any vaginal bleeding, if there is vaginal bleeding, is she bleeding a lot, like are there clots, and then is cervix open or closed, and then take a high vaginal swab. Okay, so it's kind of the examination, and history is more or less the same for PPROM. The only difference is the PPROM baby's preterm. Now, here we have to do a CTG. Okay, then we will do kind of the same things, complete blood count and CRP. Okay, and then ultrasound to confirm presentation and assess like a volume. If CTG is normal, okay. So now in PROM we are not in a hurry. If she's not in labor, just make sure that she does not have infection at the moment. We can wait depending on the hospital protocol. Some hospitals even wait for 24 hours. Okay, so that's why that what time did this happen, it is important. That's a very important question. So but in most hospitals here they wait just for 12 hours. See, if a patient says comes now, but if she says, oh my like at midday today, for example, she comes but she says, my I noticed this leaking at midnight, so it has already been 12 hours, and if she has not gone into labor, and if there is no contraindication, you can just start induction of labor. Okay, or if it's a breach and she's a primary gravid, then just perform a C-section. Okay, then oral antibiotics as per protocol. So that's it basically. The references are Obstetrics by 10 Teachers. That's the 20th edition. The last one, now we have a 21st edition as well, but I sought 20th edition because at the time of preparation I had only 20th edition. Then I looked at these RSG NICE guidelines and Green Top guidelines, and then for that one particular slide, I looked at the ACOG practice bulletin for pre-labor rupture of membranes. If you have any question, just drop a